Hello, I'm Magnus Jäderberg, Chief Medical Officer of Targovax. Today I have the pleasure to present the 12-month data of our study with ONCOS-102, the oncolytic virus, in malignant pleural mesothelioma. Now, this is a very difficult cancer disease to both diagnose and treat. And only about 10% of the patients are eligible for surgery, while the majority of patients receive chemotherapy. And the chemotherapy that we give is a combination of pemetrexed and cisplatin that's been around for over 15 years. And there's really no new treatment that's come through with any significant impact. Radiotherapy is sometimes used for palliative reasons, and immune therapy has started to make an inroad. There are a couple of checkpoint inhibitor trials in second-line disease that made it into the US NCCN guidelines, while for first-line disease and in Europe, there are no immunotherapy options for these patients. The trial that we're running is one that focuses on safety, combining ONCOS-102 with chemotherapy and immune activation. And we've looked at both first and second line patients. And we use the standard of care, pemetrexed and cisplatin, as the comparator or the control group. And in the experimental arm, we've added ONCOS-102, where we inject the virus 6 times to these patients. After a small safety lead-in, we expanded this study into a full randomized study, where 20 patients received experimental treatment and 11 patients became the control patients who only received pemetrexed and cisplatin. When we look at the characteristics of the two arms, it's important to notice a difference here. So whether you look at the number of lesions, tumor burden or staging, we can see that the experimental group had more advanced disease, and that's an important consideration as we look at the data. If we start off with first-line patients, we can see here that disease control rate is fairly similar. And disease control rate, by the way, is when we combine patients who have responded with a complete response, partial response, or stable disease. Median progression-free survival is becoming more mature now at 12-month analysis, and we see here how the experimental patients had an 8.9-month median progression-free survival, while the control group 7.6 months. We're still too early to be able to calculate median overall survival, and we've therefore calculated 12-month survival rate, meaning how many patients are alive at 12 months. And one can see here in the first-line group of patients that 64% of the experimental patients were alive indeed at 12 months, while 50% were alive in the control group. In second-line disease, control patients are performing better in general than the experimental patients. That's due to chance finding associated with a very small number of patients and the randomized design. Now, how are these data comparing with what we know historically for patients in first-line disease? Well, a good reference point, of course, is that study of pemetrexed cisplatin that formed the basis for approval in 2004 with the FDA. And that was the paper published by Ferguson and co-investigators. And what we have here is we plotted on one axis the response rate and the other axis the median progression-free survival. And one can see here that the Targovax experimental group is performing pretty well compared to historical control. So an early sign of something that we think could become very important clinically later on as we gather more data. Now, I'm particularly excited about the immune data that we have analyzed at this 12-month time point, because what we see here is a very broad and powerful immune activation across all the key parameters that we use to assess immune activation. So we see very good innate immune activation, we see adaptive immune activation, and maybe most importantly, we see a remodeling of the tumor microenvironment. A microenvironment that is able to open up opportunities for us to combine with other immune therapies. So we see in this trial how ONCOS-102 perfectly reshuffled the microtumor environment. So checkpoint inhibitors, for example, can be more effective. And in the next few slides, I will show you some details underscoring this. And the point is that ONCOS-102 has created an ideal environment by innate and adaptive immune activation, as well as other necessary remodeling of the microtumor environment. So let's go into the details. And here we have gene expression data of some key genes for immune activation listed on the left-hand side. And what we see here is a clear difference in ONCOS-102 induced immune activation compared to chemotherapy. The blue dots are represented by the control patients, and the red dots represented by the ONCOS-102 treated patients. So whichever aspect of immune activation you look at, you can see a separation between ONCOS patients and control patients. And these are, of course, based on biopsy data, where we biopsied patients first at baseline, before we treated them, and at day 36. We look at the difference between the two. So we feel that this is a good demonstration of both innate and adaptive immune activation. Another way to look at these genes is to look at those patients who achieve some type of disease control, here defined as either stable disease or partial response, versus those patients who progressed, who had progressive disease. And we've used the same gene markers. And you can see here again a very clear difference between those patients who had disease control and those who had progressive disease. So those who had disease control are here represented by red dots, and those with disease progression with blue dots. So we see broad immune activation in patients with disease control. We see very limited immune activation in those patients who had progression, and importantly, we had good local cytotoxic Th1 type immune response associated with the clinical benefit. So for the first time, some very interesting gene expression data that we believe we are the first ones to actually have produced in this disease. Other ways to look at immune activation is to focus on the all-important CD8 positive T cells. These are the immune cells that are able to kill cancer cells. And what we've done here is that we have compared those patients who were alive at 1 year and those who have died at 1 year, who died before 1 year, were deceased at 1 year. And you can see here, represented by the dark blue bar, that patients who did receive ONCOS-102 and were alive had a significant increase of that all-important CD8 positive T cell. While patients who were either deceased or received the control agent had either a much less increase of the CD8 positive T cells, or indeed, if you look at the control group who were deceased, a reduction of the CD8 positive T cells. So another example of how we are able to, with ONCOS-102, activate the adaptive immune system. Now, if we dig a little bit deeper, we can then look at the fraction or the relative number of CD8 positive T cells that were cytotoxic. And we measured here something called granzyme B. And one can see here, and again, we looked at those patients who were alive at 12 months, who had deceased at 12 months. And we look at the relative level of cytotoxic CD8 positive T cells. And again, a big difference for those patients who received ONCOS-102 are still alive at 1 year, had a much higher relative level of cytotoxic CD8 positive T cells compared to those who were deceased or received the chemotherapy-only regimen. So here, in addition to demonstrating an adaptive immune activation, we also feel that this is a good sign of remodeling of the tumor microenvironment. There's a type of immune cell called macrophage, and these can be good and they can be bad. So they can either help the immune system or hinder the immune system in fighting cancer. And the good ones we call M1 and the bad ones we call M2. So one way to look at how an immune therapy is able to change the microtumor environment is to look at the ratio of M1, M2 macrophages. And that's exactly what we've done here. And again, we've looked at those patients who were alive at one year and those who had died within that first year. And as can be seen here in the dark blue bar, the ONCOS-102 treated patients who were alive at 1 year had a significant advantage in the sense that they had a good ratio of M1 versus M2 macrophages. While for those who had deceased by 12 months or received control, either a lower change in the right direction of this ratio, or indeed a disadvantage, a change where the M2 macrophages were increased relative to M1. So a good sign of how ONCOS-102 is able to, yet again, remodel the tumor microenvironment. PD-L1 expression is something that's talked about a lot, and it's important to look to see how tumor cells respond to our treatment. And we can see here the same way we analyzed previously. We're looking at patients who are alive at 1 year who had died within that first year. And we look at fold change of PD-L1 expression. And again, the dark blue bar represented by ONCOS-102 treated patients who were alive at 1 year compared to the others, and a very significant difference in PD-L1 expression. That's of course important. Not just is it a sign of an immune activating agent that's changing the microtumor environment, but also one that would be perfectly positioned to be combined with a checkpoint inhibitor. Here's a summary of some of the things I mentioned. And we, with this spider plot, try to show the difference between the 4 different groups that we have analyzed. So the ONCOS-102 treated patients who are alive at 1 year in the dark blue lines, the ONCOS-102 treated deceased in the light blue, the controlled patients who are alive in yellow, and the controlled patients who are deceased by 1 year, represented by the red lines. And one can see here that whichever way we look at the various immune activation measures, the ONCOS-102 treated patients who were alive at 1 year had a very clear pattern and improvement in all the various ways that sets up nicely for the combination with a checkpoint inhibitor or indeed other immune therapies in the future. So to summarize, both the clinical immune data support the concept of a triple combination with a checkpoint inhibitor. We've early shown and throughout the trial that we have an excellent safety profile when we combine ONCOS-102 with standard care chemotherapy. And clinically here today, we've seen a median progression-free survival of 8.9 months, which is significantly higher than the historical level of 6 months with standard care in first-line patients. We've also confirmed the mode of action in mesothelioma, so we know what the virus actually does to the immune system in these patients. We've seen a powerful immune activation associated with clinical benefit, and we've seen the all-important remodeling of the tumor microenvironment, which may induce the sensitivity to checkpoint inhibition when given in combination with ONCOS-102. So the next steps are defined. We will continue in the first-line indication as a target population. And we're doing that because there is a strong rationale for combination with an anti-PD-1 or L1 checkpoint inhibitor and standard of care chemotherapy. And indeed, we are now at advanced discussions to collaborate with a big pharma partner. Before listening.